on porto-pulmonary hypertension, though the title is hepatopulmonary syndromes, but as we are in the Pulmonary Hypertension Summit, I decided to focus more on the porto-pulmonary hypertension component. In difference to the other talks, this particular topic is very relevant because now it involves other decisions, not just having pulmonary hypertension, treating patients so the patient get better or not. This one involves to qualify as an appropriate candidate for liver transplantation. So it has some added components that I will discuss as we move forward. My learning objectives are to briefly review porto-pulmonary hypertension and its impact on liver transplantation, describe the different hemodynamic types of pulmonary hypertension in patients with liver disease. And if there's anything you want to take out of this talk, I'll be really happy if you can get the second bullet point there, because as you will see, this is very relevant. And then present our algorithm for the management of these patients. As you can see there, this is the updated classification of pulmonary hypertension of the NICE guideline on pulmonary hypertension. And in group 1, you have portal hypertension. And so patients that have cirrhosis with the portal hypertension or portal hypertension due to other reasons, not cirrhosis, and they have high pulmonary pressures, those are the ones that are included here in this classification, part of a group 1 disease, pulmonary arterial hypertension. The definition, as kind of alluded to, is pulmonary hypertension associated with portal hypertension. It can be of this portal hypertension of intra or extrahepatic origin. We need to rule out associated conditions that are known to cause pulmonary hypertension. These patients can have obstructive sleep apnea, they can have COPD, they can have other diseases that are known causes of PH. So those need to be ruled out. And they need to have a particular hemodynamic profile. So when right catheterizations are in these patients to confirm the diagnosis of pulmonary hypertension, these things need to be looked in order to see if this profile is fit, and then qualify the patient as a porto-pulmonary hypertension individual. The pressure, the mean pressure needs to be above 25. The occlusion pressure needs to be below 15, like in pulmonary arterial hypertension patients, PVR above 3. And now this is becoming more prevalent in the definitions, transpulmonary gradient of 12. This is the difference between the mean pressure and the wedge, the pulmonary arterial occlusion pressure here. And there are different degrees of porto-pulmonary hypertension, mild, moderate, and severe. And obviously the cutoff will depend on the author, the institution, but in general, anything below 35 millimeters of mercury, so between 25 and 35, that's mild, and you will see why when we talk about the liver transplantation in a minute. And moderate to severe, anything above 35. One of the first studies came out of the Cleveland Clinic in 1991, long time ago, when the association between pulmonary hypertension and portal hypertension was presented. And these authors described that the treatment for this condition, at least in 1991, was basically palliative. There's nothing they could do. And the median survival was only 6 months for those patients, with most of them dead by 4 years. So dismal prognosis. This is a cartoon just showing you the normal pulmonary circulation, and this is what will happen in patients with porto-pulmonary hypertension with narrowing of the pulmonary areas that Dr. Farber mentioned, with thickening of the intima, hypertrophy of the media, and high pulmonary pressures with relatively normal wedge and elevated pulmonary vascular resistance. In hepatopulmonary syndrome, which we're not talking here, you have the development of these intrapulmonary shunts where blood bypasses the alveoli, so deoxygenated blood makes its way to the left atrium and the systemic circulation. So before we start going deeper into porto-pulmonary hypertension, I want to describe what is not porto-pulmonary hypertension. If you have no evidence of portal hypertension, so part of the right catheterization, you go to the suprahepatic veins and you measure the free hepatic pressure, and then you occlude that and you measure what would be the extrapolation of the portal pressure. So if you have no portal hypertension, then you do not have porto-pulmonary hypertension. If you have a very high cardiac output in the presence of normal wedge, then you do not have porto-pulmonary hypertension, you have a hyperdynamic state. And if you have a high wedge, then what you have is volume overload. This is very common in these patients because they have cardiac cirrhosis with left ventricular diastolic dysfunction, and they may also tend to have renal failure with volume overload. So those two conditions, the volume overload and hyperdynamic state, are differentiated because the PVR is below than 3. This is part of the epidemiology of the disease. Incidence of the prevalence of porto-pulmonary hypertension in patients with advanced cirrhosis is about 5%. So you see is not that common. So in referral centers like these, and you will see in the following slide, the prevalence of porto-pulmonary hypertension may vary from 5 to 10% at the most. And this is by the hemodynamic definition that I mentioned before, that specific hemodynamic definition. The first thing that starts is the portal hypertension, and then several years later, as you see there, 4 to 7, then is when you start noticing the pulmonary hypertension component. It's very interesting that the presence of porto-pulmonary hypertension does not relate to the severity of the liver disease, nor to the degree of portal hypertension. And the risk factors for the development of porto-pulmonary hypertension in patients with portal hypertension are female gender and the diagnosis of autoimmune hepatitis, the presence of large portosystemic shunts, and splenectomy. Those are the risk factors that have been identified for the development of porto-pulmonary hypertension. This is the study by Coward that showed those risk factors that I mentioned before, the female gender, the autoimmune hepatitis. Hepatitis C, in this case, it was protective. So patients with that condition had less risk for developing porto-pulmonary hypertension. This is the prevalence that I mentioned, 5 to 10. This is pretty much all across the registries. In our clinic, of the 1,320 patients with PH, 4.3% of them had porto-pulmonary hypertension, so along the lines of other studies. The pathophysiology is very interesting and is likely what it's called multi-hit hypothesis. So there are not just one factor, but a combination of factors that in a particular individual is what causes the pulmonary hypertension. So you start with some genetic factors, and there have been some genetic studies in porto-pulmonary hypertension that show that the estrogen signaling, growth factors, oxidative stress is altered, so genes that relate to that. Then you also have the splenic vasodilation, and you have the cirrhosis, the portal hypertension. Then you start releasing vasoactive mediators that will dilate the splenic circulation, but will also lower the systemic vascular resistance, so the pressure goes lower in the periphery. And so now the heart has to pump more, so you have a high cardiac output state with volume overload as the kidney is trying to retain more water and salt. And then you have the vascular shear stress, inflammatory changes as the gut is leaking bacteria and endotoxins. And when you put all of that, those vasoactive mediators end up going to the vessels of the lung, and they cause vascular remodeling. This is an interesting slide. These patients with cirrhosis and porto-pulmonary hypertension, they present with exertional dyspnea, which is pretty common in patients with liver disease. As you can see here, there are lots of causes of dyspnea with exertion in patients with liver disease. Other things that you can see in these patients are mild hypoxemia, low CO2, abnormal overnight oximetry, and a dilated main pulmonary artery, but they're not specific to tell you that they have porto-pulmonary hypertension. For this reason, as the clinical findings are non-specific, the American Association for the Study of Liver Disease put together these guidelines in 2005. Those guidelines are targeting the evaluation of patients for liver transplantation. And so they mention here that in order to evaluate those patients, you need to do a screening for pulmonary hypertension using echocardiography. They even went further and they call echocardiography excellent, which I don't agree with that, but they really like the echo. And but they made the caveat here to say that if you have a positive echo, please confirm that with a right catheterization. And they also mentioned that patients with severe pulmonary hypertension should be considered for liver transplantation only if the pH can be controlled with treatments because of the increased risk of dying during the intervention. The upper limit of normal of this right ventricular systolic pressure, which is one of the main things that's looked in the echo, at least for the guidelines that we will see in a minute for screening of pH in these patients with cirrhosis and portal hypertension. The upper limit of normal of that is 37, and you can go even higher than 40 millimeters of mercury if you're old or obese. Sometimes it's really hard to measure that. As you see, you have to have a good signal with a good envelope so you can put the marker in the appropriate place. But the good thing is that the echo provides you with other things. It provides you with the size of the right ventricle, right atrium, the diameter of the pulmonary artery, the notch in this right ventricular outflow tract if you have pulmonary hypertension. If you have pericardial effusion, it gives you this TAPSE, marker of right ventricular contractility, and other more sophisticated indices. There's no consensus on the optimal cutoff, and as you can read more, authors using ROC curves will give you some cutoffs or others, depending on what are they favoring, the false positives of the true negatives. So depending on that, the cutoff varies. So if, for example, you use a very low cutoff of 30 millimeters of mercury, the negative predictive value of that test is 100%. If you have less right ventricular pressure less than 30, no patient will have porto-pulmonary hypertension. But then lots of these patients will have to go to right catheterization to confirm diagnosis because the positive predictive value is only 59%. So Mayo Clinic, for example, uses a cutoff of 50, and with that, the negative predictive value doesn't decrease that much to 97%, and the positive predictive value increases now to 74. Here in the clinic, we use a cutoff of 45. There is a recent paper using a cutoff of 38 because they say with 38, you don't miss any patient with porto-pulmonary hypertension, although the positive predictive value is clearly lower than 74. Sometimes you cannot get a good signal The envelope is unreliable, but if you see that the right ventricle is dilated, the right ventricle is not moving well, then you want to move forward with the right catheterization, despite of the right ventricular systolic pressure. In the right catheterization, as I mentioned before, you get the pulmonary pressure, the wedge, the cardiac output, and with that you can calculate your PVR and your transpulmonary gradient. The problem of having porto-pulmonary hypertension is that it entails a bad prognosis. The 1-year survival of patients with porto-pulmonary hypertension, it varies depending on the time, from 35 to 88%. And the cause of death, this is interesting. About 50% of those patients will die from complications due to cirrhosis. Like as you see, they are bleeding, sepsis, and hepatocellular carcinoma. And the other 50% will die of right heart failure, complications of PH. It's interesting that when they compare in the REVEAL registry patients with porto-pulmonary hypertension to those that had idiopathic pulmonary arterial hypertension, the hemodynamics of patients with porto-pulmonary hypertension were better, but those patients had higher mortality, and I'll show you this in a minute. And probably the risk of dying during transplantation is higher in these patients. So this is very important because now you're putting these patients at a higher risk of dying during that, and you lose the liver that could have potentially be given to another patient. This I'm going to skip because it's not the best study. The 2-year survival in the REVEAL registry, as you see here, and now we're going to be focusing on incident cases, or newly diagnosed cases, because usually prevalent cases were diagnosed before the inclusion in the registry, those cases tend to live longer. So of the newly diagnosed cases, as you see here, the idiopathics at 2 years they have a higher survival than those with a new diagnosis of porto-pulmonary hypertension. So it's a big gap. So these patients clearly do worse. So yes, in part because of the cirrhosis, but in part because of the PH. So there is this number, a number of 35. That when you do a right heart catheterization and you have a number in this patient, so 35 or above, then there's a big problem because the patient will be rejected from transplantation, at least at face value. And this is because on this retrospective study of Dr. Krauka at Mayo, when they review cases of patients that underwent liver transplantation that were found to have an elevated mean pulmonary pressure during the swan placement, they noted that all the ones that had a mean pressure of 50, they all died during transplantation. Those that had a mean pressure of 35 to 50, here they had a 50% mortality. The ones that had a mean pressure of less than 35, they all survived. So that's why it's considered mild porto-pulmonary hypertension, the mean pressure of 35 or less, because, all these patients survived when they were undergoing transplantation. Those that had a higher pressure, those are a higher risk. So the higher the pressure, the higher the risk, especially when it goes above 50, when none of them survived the intervention. So you don't want that. For that reason is that we tend to treat those patients because they do poorly during transplantation. Why do they do poorly? Obviously, you have stressors associated with anesthesia. The patients are a lot of anxiety, getting a liver transplantation. They receive medications. They're put on a mechanical ventilator that alters the hemodynamics. They get lots of fluids. They have something called reperfusion syndrome that I'll show you in a minute, but lots of volume shifts as they clamp and unclamp inferior vena cavas and portal veins. And then they're replacing a liver with a liver that has had some ischemic time, so that when the liver is put in, it releases vasoactive mediators, cytokines that are vasoactive, and also can be some thrombi going into the pulmonary circulation. All that can lead to right ventricular failure. So as you see here, this patient had the systolic, mean, and diastolic pressure at these levels. When the new liver was put, and it's called a reperfusion, the liver is reperfused, boom, there is a jump in the pulmonary pressures that if your right ventricle is not able to manage, you see here the cardiac output went up to 15 liters, then you can have right ventricular failure and die during the intervention. The goal of treatment in these patients are you want to make them feel better, improve the quality of life, the functional capacity, and facilitate a successful transplant. Probably this is the most important component. We give oxygen if the PaO2, the arterial oxygenation is less than 60. Diuretics, you have to be very careful because hypertension and acute kidney injury can occur. You do not want this patient to be on beta blockers, calcium channel blockers, or anticoagulations. No evidence of its use, and beta blockers may even worsen this condition. So one of the main objectives in these patients is just you give treatment in order to lower those pressures, in order to lower the risk for the liver transplantation, so they can get the liver and they can go through it and make it. But as you see, this different series, UCLA, Mayo, and Baylor, they had a good number of patients, 36, 74, and 30, and they all received, the majority received some treatments, and a third probably improved and were transplanted. And those that improved and were transplanted had a good 1-year survival. So this is what I was talking to you about the beta blockers. There is a study where instead of giving medications, they withdrew the beta blocker therapy, and these patients increased the cardiac output, the exercise capacity. So when you give beta blockers, if you were to give, you have to consider very carefully the risks and benefit of this treatment. In general, because there are no randomized studies in this condition, PH therapies will improve functional capacity, and this is mainly based on retrospective analysis, case series, but no randomized controlled studies. Except for the patent one that include 13 patients with porto-pulmonary hypertension. All the other randomized studies done in PH did not include porto-pulmonary hypertension. So we have our data is biased by not having the well-designed studies, at least up to now. The medications that we prescribe to patients may also have adverse effects that are particularly of importance in patients with liver disease, such as they can cause thrombocytopenia that those patients already have, like the parenteral prostacyclins, and some ERAs, like bosentan, can increase the transaminase more than 3 times in 6% of the patients. You have to be careful if you prescribe bosentan on these patients. However, there have been 2 studies using bosentan with decent 1 and 3 years survival of 94 and 89 there. There's another good study using ambrisentan in these patients with normalization of the PVR in 5 of them, like 50%, a little less than 50% of the patients had normalization of PVR, so great response there also with ambrisentan. With the PDE5s, there's also in general some improvement, although the numbers are very limited, but very important here is that you may improve at 3 months, and this is when they suggest you have to recath the patient to show this improvement. But then maybe that improvement may not be sustained long term. So when we talk about MELD exception points in a minute, you will see that you have to repeat the catheterization every 3 months in order to show that the improvement that you got persists over time, because if the improvement disappears, then you're no longer a candidate for liver transplantation. So this is another very critical point. So you start treatment on these patients, and you see here, I'm talking about this mean pressure of 35. So you start treatment with prostacyclin, for example, IV Flolan. And this was done in 48 patients. Data comes from 5 retrospective studies. You start treatment, the mean pressure decreases, but it doesn't decrease as much as you would expect it. And this is because as you are decreasing the pulmonary vascular resistance, the cardiac output goes up, and with that, the mean pressure doesn't decrease that much. So as you see here, the PVR decreased on average 52%, while the mean pressure only decreased 25%. So this will be important because of this cutoff of 35 when we talk later about the MELD exception points. Once you transplant these patients, you treat them, the pressure decreased, and you transplant them, they do pretty well and comparable with other patients without porto-pulmonary hypertension. This is what I was just mentioning you, whether when they do the surgery, they clamp the inferior vena cava, they clamp the portal vein, and as you see, when they put the new lever and they release this, it's a bunch of blood going to the right ventricle, which is already not function well, and giving a fixed pericardial sac that will cause this compression of the left ventricle due to this ventricular interdependence, decrease in the blood pressure, and shock and other things. So there are other ways that they can do these. They can preserve the inferior vena cava. They can also connect, for example, preserve the inferior vena cava and connect the portal vein to the inferior vena cava to preserve the blood going to the right ventricle. There's something else that they can do. It's called venous bypass. So they get blood out of the femoral vein, blood out of the portal vein, and then they put it back on the axillary vein, so bypassing this clamps that they put in there. And then the good thing about that is that if you have a diagnosis of porto-pulmonary hypertension, confirmed diagnosis of porto-pulmonary hypertension, and then you receive treatment for it, and then you improve your mean pressure to less than 35 with a PVR less than 5, and you have the satisfactory right ventricular function, then you qualify for 10% increase in MELD points that every 3 months you could keep on getting until you get transplanted. But as I mentioned, the mean pressure may not decrease as much with treatment due to these increases in cardiac output. And in general, MELD exceptions are not granted if the mean pressure remains above 35, even when the PVR has a dramatic decrease. And this is very interesting. In Coward et al., they study patients from 2006 to 2012, all the ones that received MELD exception points due to porto-pulmonary hypertension. And incredibly, 1/3 of them did not fulfill the porto-pulmonary hypertension definition. So 1/3 of them, they don't even have porto-pulmonary hypertension, and they end up getting MELD exception points. So that's why I was just focusing on trying to identify the appropriate profile, the same profile that I show you. So 1/3 of them didn't even meet that. And another, about 50% of them did not meet the formal exception criteria. So this will have to obviously be revised as half of those patients didn't meet the criteria for MELD exception. So in our clinic, we do echocardiography on these patients. The patients are considered for liver transplantation. If the pressure is less than 45, and this is an arbitrary cutoff, it can be 50, for example, or even lower, depending on what you want to favor. you proceed with liver transplantation. If it is above 45, then right heart catheterization. And if it is, then you do the right heart catheterization. If it is less than 35, then you move with transplantation. If the mean pressure is above 35, then you consult pulmonary. And then we will rule out the causes of PH, and then we'll start treatment. And if the pressure lowers than 35 with a PVR less than 3, we will then recommend transplantation. And as a summary, the porto-pulmonary hypertension is uncommon, but it's associated with higher mortality. You screen by echo, and you have to confirm that by right heart catheterization. You have to differentiate the different profiles that I show you, PH in cirrhosis with portal hypertension. And then the treatment usually improves quality of life, proven survival benefit, and may improve your candidacy for liver transplantation. A multidisciplinary team here, as I emphasize this, is critical. And that's it. Thank you for your questions.